I'm Johanna Ralston. I'm Chief Executive Officer of the World Heart Federation, which is the host organization for the World Congress of Cardiology. I'm also on the steering group of the NCD Alliance. It is my pleasure to welcome you here today to our morning session on Roadmap to 25 by 25, a decade to make a difference in tackling heart disease and stroke. 25 by 25 is a phrase that you'll see expressed in our tagline for the Congress, which is 25 by 25 at the heart of global health. It's also a phrase you've probably heard about and read about. I'm here to tell you just a couple of words about what that means for the global health community and specifically for the global cardiovascular disease community. And then we will hear from our distinguished panel of leading experts from around the world. 25 by 25 is reflective of a WHO target which was adopted by the World Health Assembly, the governing body of the World Health Organization, 1 year ago in Geneva. 25 by 25 reflects the commitment to reduce premature mortality from non-communicable diseases, cancer, cardiovascular, diabetes, and chronic respiratory, by the year 2025. As it turns out, 2025 is just about 10 years away, so there's quite a lot to do. But the 25 by 25 target emerged from the UN high-level meeting in 2011, where there was recognition that, in fact, non-communicable diseases have emerged to become the leading health burden for the 21st century, with cardiovascular disease leading amongst them. Cardiovascular disease is responsible for 1/3 of all deaths in the world and half of all NCD deaths. And the majority of those are occurring in low and middle income countries. So the world clearly has changed, and it's time for us to create goals and political processes and policies, as well as implementation plans to get to 2025. I do want to note that this session is being recorded, and we have a number of journalists from all over the world who are going to be covering this issue. And specifically, when we speak about roadmaps in the title of the session, that reflects the World Heart Federation commitment to make roadmaps around 3 of the WHO targets in particular: hypertension, secondary prevention, and tobacco. Roadmaps which are taking the World Health Organization Global Action Plan and taking it one step further for the cardiovascular disease community, for governments, public and private and nonprofit sectors, to achieve the hypertension, secondary prevention, and tobacco targets of the World Health Organization. So roadmaps are really plans we're all coming up with jointly. We've convened global experts here to help us define how to get to 2025, 25 by 25. And we're looking forward to hearing from our experts today. Without any further ado, it's my pleasure to welcome Douglas Betcher from Geneva. He is with the World Health Organization, and he is director of the Prevention of Non-Communicable Diseases Department. Thank you, Douglas.
Thank you, Joanna. I don't want to have death by PowerPoint this morning, but I thought I'd have just a few slides just to illustrate some of the concepts that Joanna was referring to. So can we flick those up? Yeah. Great. So great to be briefing you this morning. Journalists are certainly going to be major allies, major advocates to move forward and translate the concepts of non-communicable diseases into meaningful stories that will make sense to publics and the audiences that we want to target. Why the 25 by 25 targets is important. As Joanna mentioned, non-communicable diseases are one of the greatest health challenges facing humanity at the present time. They've come from a history of being underrepresented, underreported, and really misunderstood, and having up till the early part of this century a much lower priority than they deserve. When we look at what non-communicable diseases, as Joanna mentioned, we're talking about the lion's share are cardiovascular diseases, but also diabetes, cancer, chronic respiratory diseases, and then there are underlying risk factors, and those are physical activity, unhealthy diets, tobacco, and harmful use of alcohol. All of those contribute to cardiovascular diseases. We've tried also in WHO and with partners to try to find a better term, another term to non-communicable diseases, which many have criticized to be a rather dense and opaque term. And we consulted some of the best communications and experts in the world, and guess what we came up with? Non-communicable diseases. So yeah, we just need to unpack it and tell stories around it. And as I said, that's really very important role for journalists as partners in this effort. So the 25 by 25 target, as Joanna had mentioned, is a 25% relative reduction in premature mortality from non-communicable diseases by 2025. So it's all about not dying too young. Millions of people are dying much too young from non-communicable diseases. We have the solutions at our hands to avert most of the cardiovascular diseases and other non-communicable diseases deaths. And when we talk about premature deaths, we're talking about 30 to 69. And the latest figures that the World Health Organization has issued are that of about 36 million deaths from non-communicable diseases per year prematurely, about 13.8 million are premature. And why this effort is important is that we can prevent many of those premature deaths. The way that Australia, for example, has adopted cost-effective interventions, for example, in the area of tobacco control, and prevented millions of deaths in the process. And that's what we need to talk about. That needs to be the focus. And a part of the misunderstanding as well, too, is up to the early part of the century, it was understood that non-communicable diseases were problems only of high-income countries. And this map really does unpack that myth. In fact, the countries in dark blue are countries where the probability of dying prematurely, so between ages of 30 to 69, are over 25%. And if we look at this slide, most high-income countries, Australia, Canada, much of Europe, the probability of dying prematurely from a non-communicable diseases is less than 10%. So you have a situation in Africa as well, too. You see many countries here where the probability is over 20 or over 25% of dying prematurely. So you have a double burden of non-communicable diseases, maternal child health, communicable diseases, and health systems that are very unequipped to deal with these double burden of disease, and creating really a crisis which is not only a health one, is also very much a socioeconomic one. In a time of financial crisis and mountains of debt worldwide, the non-communicable disease epidemic is very, very much an economic threat. And this was reiterated in what we call the cost of inaction. On the left-hand side, Harvard University and the World Economic Forum estimated in year 2011, if the world sits on its proverbial hands and does nothing between 2010 and 2025, it will cost at least $7 trillion for developing countries in lost productivity. And this compares to an estimate that WHO provided that if we scale up actions in low and middle income countries, a cost-effective set of best buy interventions, which we have tested in countries at all levels of development, about $10 billion a year would be required to address the bulk of these premature deaths. And in comparison, this is a very small amount, and certainly a very good investment. So what does it mean in the next 10 years, the 25 by 25, and the role of WHO in this process? WHO, with our member states and partners like the World Heart Federation, have been involved right from the start of this, and especially the early part of the century, in trying to unravel this, trying to understand better the importance of non-communicable diseases. Our member states have adopted strategies going back to year 2000, the first global strategy for non-communicable diseases, a project that I was very much involved in the Secretariat in WHO, which led to the adoption of WHO's first treaty, the Framework Convention on Tobacco Control, the first legally binding treaty adopted by the World Health Organization member states, a number of strategies addressing diet and physical activity, harmful use of alcohol, marketing of food to children, and then the culmination really in 2011 was the heads of state meeting on non-communicable diseases at the General Assembly. Only the second time in the history of the General Assembly that heads of state meeting on a public health topic was held. The first time was HIV/AIDS, and that really provided a turning point in increasing the priority, a paradigm shift in increasing the priority of non-communicable diseases. The architecture is built now, and the last major part of the architecture is adopted by our member states, the Global Action Plan for NCDs, which envisages a world free of avoidable burden of NCDs, and develops a number of objectives, which involves recommended actions for our member states, our international partners, and WHO, particularly to increase the priority of non-communicable diseases on the development agenda, also to encourage multi-sectoral partnerships, working outside the health sector, actions and cost-effective best buy actions to address the modifiable risk factors, which I mentioned, and also in objective number 4, the need for bolstering health systems, which are particularly fragile in developing countries vis-a-vis non-communicable diseases. And also objective number 6, in the words of our Director General, Dr. Chan, what gets measured gets done, and we need to strengthen the surveillance systems in developing countries. And to help to move forward this process are the targets that Joanna had mentioned. For the first time in public health history, we have internationally agreed targets to motivate the global and country action by governments, UN agencies, civil society, other non-state actors. So to complement the 25 by 25 target, we have 6 targets in blue, which are targets to reduce the metabolic and behavioral risk factors, reduce the harmful use of alcohol, physical inactivity, reduce salt and sodium intake, a major cause of hypertension, cardiovascular diseases, tobacco use, raise blood pressure reduction, maintaining diabetes and obesity, 0% increase because there has been such a huge increase in both over the last 20 years, and then also encouraging strengthening of health systems and better treatment in health systems. And we know the job can get done. Let's look at this slide. Countries that have adopted what we call the Empower measures in the Framework Convention, the measures that we know will reduce demand for tobacco use, full bans on smoking in public places like we have in Australia, strong pack warnings, the best of which in the world. The gold standard is the plain packaging adopted by Australia, complete bans on advertising, promotion, sponsorship, tax and price increases. We've graphed out here countries that have a number of these measures adopted at the highest level, and we see that Australia, Uruguay, and Turkey, for example, have enjoyed regular and quite precipitous decreases in tobacco use because of their efforts and their political will to get the job done. We have the solutions at our hand, and we can move forward. The same, very important to cardiovascular diseases as well. Salt reduction. WHO has a package of a salt reduction package like the Empower package that we're ready to scale up, and we know that this can also save millions of lives, and we know it's doable in countries at all levels of development. I know our colleague from Lancet is here, so I won't elaborate on this much, but the excellent article just published in the Lancet over the weekend is really a strong proof of concept that how to achieve the 25 by 25 targets. As the authors modeled the risk factors, they have shown that 16.1 premature deaths can be averted or delayed, and that 86% of those deaths will be in developing countries, and 71% of those averted deaths will be CVD deaths. And particularly referring to tobacco control, if the targets are more ambitious of over 50%, then almost the 25 for tobacco use, the targets of 25 by 25 can almost be met. And then WHO works with partners to build infrastructure. We also measure the infrastructure that countries have in place. Progress is being made. However, I pointed your attention to the third line on this slide, fourth line actually. Countries with integrated operational policies or plans for NCDs with a dedicated budget. We've seen increases from year 2010 of countries that have fully financed NCD plans from a third to 50%, but still this is the Achilles heel of our work, the fact that many countries yet do not have operational mechanisms to move forward the NCD agenda. And just to finish off, it's all going to be about working together in partnerships. And I think even our panel here for the press conference here today shows how different stakeholders need to work together. And there was a major meeting in Geneva a couple of weeks ago where our member states looked at and negotiated a proposal for bringing together different stakeholders, academia, private sector, civil society, UN agencies, member states, to better coordinate the different stakeholders towards a common NCD agenda. It's called the Global Coordination Mechanism, and if targeted and scaled up, it will help very much to accelerate the implementation of the Global Action Plan and the attainment of the 25 by 25 targets, which basically we cannot make the 25 by 25 targets unless cardiologists and the CVD community embrace this urgent mission, and journalists and your journalistic community will be very important in this endeavor. Thank you.
Thank you very much, Douglas. I also wanted to mention that at the end of the panel today, we have Dr. Stuart Spencer, executive editor of Lancet, and also one of the co-authors of the lead authors of the study that you mentioned, Professor Majid Azadi, is here with us as well today. So we'll have a chance to hear from both of them on the very important piece that just came out in Lancet. Australia is not only host to the World Congress of Cardiology and a beautiful country, but also really a leading light in addressing non-communicable diseases. First, domestically, in terms of its leadership role in tobacco control, but also as a source of official development assistance and a real leader in terms of calling attention to this transition where non-communicable diseases are truly problems of low and middle income countries. And so it is my great pleasure to welcome our next speaker, Professor Jane Halton, who is Secretary of the Department of Health of Australia. She is also chair of the World Health Organization Executive Board. Professor Halton.
Thank you. I thought I might stay here as I don't have a PowerPoint. So sort of standing, waving my arms without anything to point at doesn't necessarily make for a very good interaction. Can I start by welcoming people to Australia and to Melbourne, where I can't describe it as sunny, and I did hear someone saying it's actually colder than Geneva.
It is.
It doesn't get as cold as Geneva, though, I can tell you that with confidence. Can I also, as we're in Australia, acknowledge the traditional owners of the land on which we meet, their elders past and present. And that's particularly important for us because in our country, a developed country, which has seen a 78% reduction in age standardised mortality, we now are at a point in the policy development process where we're looking at particular subpopulations who have not enjoyed the same decline in mortality that others have. But I'll come to that issue in a second if I can, because I want to talk to begin with about why it is that national policies are so important in taking the global frameworks that Douglas has rightly outlined to the coalface, to the practical place where these things are implemented and where they're going to make a real difference to the lives of individual citizens of all of our countries. And I think it is important that we realise that we can write all the global frameworks that we wish, but if individual policymakers, if individual clinicians, if individuals do not work together to achieve those targets, we will achieve nothing. And it is a reality that this needs to be a partnership. So if we think about the policy frameworks within which I work as a policymaker and as an administrator, those policy frameworks have to firstly encourage, secondly inform, thirdly enable, and fourthly, and most importantly, and Doug's already mentioned this, measure. Because as he has already said, and I was going to refer to this as well, as our Director General says a lot, what gets measured gets done. So if we do not, as part of our policy framework, have a very clear focus on what we are achieving, who is getting access, and what is working and indeed what is not, we will not actually achieve the 25 by 25 targets. So I think my first message is that to make policy real, we have to know whether it is delivering. So for us in this country, that 78% figure I talked about, that was underpinned very much by the science, and it certainly preceded a global framework, I have to say. But it was underpinned by a solid grasp of the science and then access to the relevant pharmacotherapy, statins, antihypertensives, etc., together with the clinical interventions that would make a difference. So these things drove the numbers that you see in this country. But importantly, the prevention message was also adopted very early here. So the impressive graph that you just saw, which sees us heading to world lows in tobacco use, this is not something we have achieved overnight. So one of my other messages about policy and its importance is also another P, and that is persistence. Because ultimately, if the policy framework is adopted and then not given time to mature and is not reinforced at every available step, you will also achieve nothing. So if we take tobacco, and tobacco is something which we are absolutely determined about in this country, and you will have seen the work that we've done on plain packaging. You will have seen the vigorous attack we have been under from big tobacco. As I say, if I'm going to be not popular, I'm very happy to be not popular with that group of people. Bring it on. Essentially, we have taken methodical, evidence-based steps to drive down tobacco use in this country. And for us, plain packaging was the next logical step in this methodical journey that we have been on to discourage people from using substances which are basically bad for their health. And of course, when it comes to heart health, we know that unlike the cancer risk, you get much faster benefits from tobacco cessation. So again, this is something which actually helps underpin our policy approach, knowing the clinical evidence that says in 12 months you are going to start to get real benefits from tobacco cessation. That enables us to convince politicians, it enables us to mobilise individuals in our community to actually keep this fight up. So there are a number of things which need to underpin your policy approach, and we need to be very careful to make sure that we put a tick in every box. So we need to know what interventions work. That means keeping across the science and keeping it current. And we all know that the science of 40 years ago when we started on this journey was not the same as the science today. We also know that we do need access to medicines. And access to medicines at an affordable price, particularly in low to middle income countries, is something which I know all developed countries are very concerned about, and is work that is being very conscientiously done by the WHO. And being able to ensure that people do get access is incredibly important. Importantly also, though, is that we actually have the clinical underpinnings, the clinical guidelines and frameworks that our professionals working in our hospitals, working in primary care, actually understand what it is that they need to do. And they need to have that continual reinforcement, data about their performance, data about the outcomes, so they can continue to improve that clinical work. And we also need to ensure that there is a national, in every country, framework around prevention. And just as has been indicated, this is one of the areas, a dedicated budget inside individual countries focused on prevention so that people can actually understand but also have access to the resources to deliver the messages, not just to the policymakers, not just to the politicians, but to the individual citizens who must themselves also take action. Douglas has taken you through the risk factors, the things that we need to actually tackle if we're going to achieve 25 by 25. And we all know from those risk factors that a clinician cannot influence on a day-by-day basis whether in fact sedentary lifestyles are going to be a feature of your population. We have to actually mobilise individuals to take action. I have a party trick I often use when I give speeches domestically. I'll be talking about harmful alcohol use, I'll be talking about tobacco, and then I'll say, now, all show me how much a standard drink is. And people look at me, and no, with your fingers, and I say this. And then I say, how many standard drinks can you actually have in any one day? and there's a bit of mumbling and people look into their laps. And then someone, usually a woman, will say, 2, Jane. I'll say, correct. And I'll say, and how many for the men in the room? And they all shuffle. I go, yes, it's the same for the men. It's one place where we have true gender equality. And then I ask, how many of you have been out and done some exercise this morning? How many of you have been out and done some exercise this morning? A few. Exactly. Because ultimately it's individual actions inside that policy framework that are going to make the difference. It's everything from medication compliance, inactivity, tobacco consumption, the question of how much alcohol you consume, and what happens in terms of the food that you eat. The notion that you need to think about salt, you need to think about fat. And of course, there are a number of things that we can do from a policy framework, but we need to mobilise individuals. And the policy framework we have within individual countries needs to recognise and deliver on that. So we in Australia have a clear notion of the policy framework and a clear notion of how we tie together the individual, the clinician, the government, and the system within which we operate. We have a clear notion of ensuring access to pharmaceuticals, to appropriate clinical care, including surgery, and how it is we can assist individuals to make the right decision in relation to their individual behaviour. But we're also very conscious that as a good global citizen, we also need to work in partnership with other countries. And one of the other messages I want to give you about the importance of national policies is the importance of national partnerships with other governments, with NGOs who work across regions, and also from a clinician to clinician, from an individual to individual basis. And for us, our backyard is the Pacific. And if you look at the challenges in the Pacific in terms of cardiovascular disease, in terms of heart disease, in terms of stroke, in terms of diabetes, they are enormous. And if you look at the risk factors across the Pacific, they are similarly enormous. So one of the things that we have as part of our national policy suite is an approach to aid, it's an approach to assistance, which is similarly based on evidence. It's similarly based on partnership. It is similarly based on respect and the need to galvanise individuals. And so for us, that is part of our national policy suite. We are a developed country. We are very fortunate that we have a first world health system. And it is important that we reach out to work with our friends and colleagues across the region. Now, I could talk for much longer about health systems and how we work inside a health system, but I'm conscious that no single health system is like any other, and whilst there's some things that individuals can learn from others' experiences, you can't simply graft one health system on to another. It doesn't work that way. So what I can reinforce, though, is that for us, a constant focus on measurement, a constant focus on evaluation, and most importantly, keeping the science at the core of what we do underpins our national approach and our national policy. So I might leave it there, and I'll be very happy to answer some questions. Thank you.
Great, thank you very much, Professor Hoppers. We will be leaving questions and answers till after all of our presenters have spoken. Now it is my we heard about the importance of working across sectors and with multi-stakeholders. This is not a problem that any single sector can resolve. It's not a problem that the health community can resolve, because the issues associated with it are so broad and involve things like, transportation, food, trade, other issues. So it's my great pleasure to welcome two leaders of sort of civil society and the clinical side from two different countries. First, we have Mary Berry, who is Chief Executive Officer here in Australia of the National Heart Foundation of Australia, and with her we have Dr. Marcia Barbosa, who is president of the InterAmerican Society of Cardiology and also a cardiologist from Brazil, based at the Eco Center Hospital Belo Horizonte. I cannot say it in her beautiful lyrical Portuguese, but she will, and you'll all get to hear. Marcia and Mary will actually just have a brief discussion about a brief presentation about the multi-stakeholder element of this.
Thank you very much, Joanna. Well, I suppose with the National Heart Foundation, we obviously realise that greater action is required to prevent heart disease and stroke, which are actually two of the single biggest killers in our nation. So to enable us to do that and work with other stakeholders and not just to be internal focused, we've also just released the Australian Heart and Stroke Charter. And this has been done in partnership with a number of different key agencies right across Australia. And all these agencies have literally signed up to this document. So there are 5 key prevention issues within the document, 5 key issues that we really want to push. And the first one is to prevent heart attack and stroke. The second one is for early detection, which is to obviously try and identify people as soon as we can who are at risk of having heart attack or stroke. And then we need early treatment. And what we're trying to get to do there is for people out in the community to take some responsibility also and to look and be able to observe warning signs of a heart attack. So what we're trying to get people and family members and friends to do is if somebody is showing symptoms or has symptoms of a heart attack, to make sure that they take action quickly, because the sooner you can get treatment, the better the outcome for the person suffering the signs. We also want to improve quality of health in hospital care and to boost CVD research. And again, making sure when people get to hospital that they actually get the appropriate care and that they're referred to the right services. And once they've had that initial care, to then be sent to rehabilitation, which is also very important, because as we know, when people leave hospital, and just what we were talking about is individual choices, they don't always follow the advice of their medical practitioners and clinicians, and at times don't take the medication, and certainly don't do what they're being asked to do to maintain lifestyle. So again, rehabilitation and that support is extremely important. And one of the key things we really want to push is what we call our absolute risk assessments. And we'd really like to see more of these integrated health checks. And what they screen for is risk of heart attack, stroke, type 2 diabetes, and chronic kidney disease, and this is in general practice. And even despite the benefits that this has for people, we still have only about 5 and 10% of eligible patients in Australia having had their risk of heart attack or stroke assessed in the last 5 to 6 years. This means that really too many of these people now are ending up in hospital because they've had a heart attack or stroke when their condition could have been detected and managed in the community. So we really want to get people to think about the risks they're facing and to make sure they have that general check and that discussion with their GP so that their risks can be analysed and managed. And some of the risks we're facing in Australia is we have more than 9 in 10 adult Australians have at least one risk factor of cardiovascular disease, and 1 in 4 have 3 or more risk factors. 1 in 5 Australians have high blood pressure. Now, that's a lot of people out there, and many of those are completely unaware that they have high blood pressure. And 1/3 of Australians have high cholesterol, and over 9 million Australians are either overweight or obese. And 1 in 6 Australians aged 15 or over are smokers. We've made some great inroads, as Jane has pointed out, in that area, but obviously we still have a bit more to do. And more than 1/3 of Australians do little or no exercise at all. So we're really wanting to work with all the agencies to get our charter out there to look at prevention, early detection, early treatment, improved quality of care, rehabilitation and support. Thank you.
Thank you very much, Joanne, for this opportunity. I am Márcia Barbosa from Brazil and president of the InterAmerican Society of Cardiology. And coming from developing countries, our reality is very different. I'm very jealous of the numbers I have heard here. Unfortunately, Brazil and other countries in South America are not in that position. We have progressed a lot, but we still have a long ways to go. And the real sad thing about countries in my part of the world is that we still have a high mortality, maternal mortality, infant mortality, rheumatic heart disease, Chagas, and all these neglected diseases. And on top of this, we now have the big problem of this increasing cardiovascular burden, causing many young deaths. So the situation in our country is much more complicated because we have to face both problems. They are still big problems. And the most important thing, since here we are talking about cardiovascular disease, is that people are not aware of this. So if you talk about women, for example, before the American, and all these numbers that I'm going to say are American numbers, so of course the situation in our countries is much worse than that, and unfortunately we have very few measures, and I agree measures are essential, but we have very few in developing countries. But before the American Heart Association campaign trying to make women aware of the importance of cardiovascular disease in their lives and as a cause of premature death, 66% of the women did not know that cardiovascular disease was the main cause of death among women. So with all the campaigns that have been around the world about that, this has really decreased. I mean, the awareness has increased, has doubled, and with only the position of more people being aware of this, the rate of mortality has decreased 50%. But then it reached a plateau. And the main thing about this is that there is still, although the rate of death has decreased and awareness has increased, there is a big gap according to ethnic and socioeconomic levels. So the people with different ethnies, especially Hispanics and other ethnics, still have big problems, and awareness is less among these people than among, for example, white people. And so we have cases like, for example, Mexico, where the incidence of diabetes is extremely high, and we have problems like this. So we really need to decrease the gap among the different ethnic groups. So this is why it is so important to do these campaigns. And this is something that, as everybody here has said, cannot be done by cardiologists alone. We cannot fight this fight all by ourselves. We need government, we need rules, and most of all, we need other physicians, other professionals. If you think about the time that cardiologists have to spend with their patients talking about risk factors, very little. A survey in the United States showed that 20% of the women said that, only 20% said that their doctors had spent some time with them talking about risk factors, which is terrible, but this is the reality. So many times the cardiologists don't get to see the patient, so we need other health professionals to be involved. Many times the gynecologist is the one who gets to talk to a woman, or the internist to all patients. So we really need to do campaigns in order to motivate other professionals to get involved in fighting cardiovascular disease. And the InterAmerican Society and many countries in the three Americas are doing a great job throughout their organized cardiology societies. So in Brazil, I can talk more about Brazil because this is where I come from. So we have done a very good job in terms of decreasing tobacco use. In 2003, we were the first country in South America to adopt strong rules against merchandising cigarette smoking, and we have had a 30% decrease in tobacco use in Brazil. So we're happy, but we still have a long ways to go. And the society has done a lot of other things in terms of training other professionals, health professionals. For example, last year in Rio, we had a press conference like that. Mm-hmm. And we also trained, during the Congress of Cardiology, we trained 2,000 people, laymen, people from the community, on risk factors and how to face emergencies, cardiac emergencies and things like that. And this is an ongoing program. So we have that for the community. We also have continued education for Brazil. It's a huge country like Australia, so we have continued education online to reach out cardiologists and general practitioners throughout the country. We have started a few years ago a very interesting program with children, so volunteer cardiologists who volunteer to go to schools and train teachers and other people in schools to talk to children about nutrition, about exercise, and about all that. And many other things. For example, Brazil is a Catholic country, so one of the things that our society, the Brazilian Society of Cardiology, has been doing is to train volunteers from the church so they can spread the news and the knowledge about risk factors to a much larger population. And now with the World Cup and with the Olympics next year, we are having a good opportunity, and television has been talking a lot about exercising, and we hope, among all the money that was spent with those crazy stadiums that have been built everywhere, we hope that at least we get some good points, and one of them we hope that is to get people interested in exercising more and more. Thank you.
Thank you very much. The World Heart Federation had the pleasure of working with the Brazilian Society of Cardiology around training journalists last year in 25 by 25 so that we could start to generate media coverage. And that is a nice segue to our next and final speaker, who will speak about the influence of media on global and national health policy, Dr. Stuart Spencer, Executive Editor of The Lancet. Thank you.
Thank you very much. Good morning. I feel a bit of a fraud. Oh, okay, use this.
We're being recorded.
I feel a bit of a fraud being here and talking about 25 by 25 when the author of the paper is sitting there. He knows much more about it than I do, but I can talk a little bit about the Lancet and the role of the media, perhaps. And you may forgive me if I argue some points that other speakers have made. It's just for the sake of making some discussion here, you know. Okay, so the Lancet is very interested, of course, in non-communicable diseases because the Lancet is a medical journal, and non-communicable diseases make up the vast majority of medicine. You know, it's not to say that there is no problem with infectious disease anymore. Of course there is. And although we've made huge strides in overcoming many of them, it's a relatively small proportion of global disease. So most of medicine, most of what the Lancet wants to do is non-communicable diseases. The big things, cardiovascular, which is why we're here today, of course, but also respiratory, Alzheimer's, burgeoning problem, depression, another mental health issue, non-communicable disease, huge problem, injuries, hopefully it's getting smaller and smaller as time goes by. But, you know, they're big business for us. So we're very interested. And, of course, the Lancet, as you probably well know, has a particular interest in developing world, medicine in developing world. And we've heard from Douglas already that NCDs are huge in the developing world. Not so much of a problem in Australia and UK and the USA, for example, anymore. Although we've put an awful lot of effort into trying to deal with them. Mainly because we don't have so many infectious diseases, which is good fortune where we are. So it's definitely a Lancet topic. What can the Lancet do to help with this? Well, of course, we can publish these papers, and we do also get involved with advocacy and so on. But I think where the media in general can be involved is in providing genuine, strong messages. By which I mean, let's not keep peddling particular scientific quotes, facts, bits of information that don't necessarily reflect what is true, but they're convenient tools for people to use as a message. You know, any paper that you pick up, at least in the UK, you'll find something that says, coffee's bad for you. And the next day, headlines, coffee's good for you. Smoking's bad for you. I think everybody knows, nothing comes across that. But you know, you get the drinking's bad for you, red wine's good for your heart. You know, every day there's a different message. This is because we're peddling untruths in the media. They're good stories, of course. People love to read them. If you like drinking red wine, you take that one on board and you ignore that it's bad for you and so on. You know? So there are lots of things that the media, I think, can be criticised for, and maybe some of our advocacy at the Lancet as well, perhaps. So I think the important message for the media is to get the facts right. I think we can all agree that smoking's bad for you, and we've made some wonderful strides in getting rid of smoking as a problem. I don't want to pour water on the parade, as it were, but it's a relatively easy target, smoking. Of course, a lot of people enjoy smoking, but it's a sin, It's not actually what you need. And so it's very easy for governments to impose taxes and say, yes, we'll do away with this and so on. Tackling food, which is what we've been talking about, is rather more difficult. We all know intuitively that food is good for us. So it's very difficult for governments to then turn around and say, well, you can't eat this because it's bad for you. And unless the messages are really strong, and I would take salt as an example, unless the messages are really strong and clear and honest, you're going to run into problems. We're going to hear from Professor Yusuf this week about the PURE study and how he thinks, or his results suggest, that salt may or may not be important, how important it is. And that compares probably, from what I've seen so far, dramatically with the anti-salt messages that are around. I'm not saying that everybody should have lots of salt or anything. I'm not saying it shouldn't be reduced. But I think the message needs to be honest and backed up by scientific facts, hard scientific facts. I know there's a lot of evidence out there that salt is harmful, but there is an awful lot of evidence that in a normal population, normal intensive population, it isn't actually so bad. Even the zealots like McGregor, producing his meta-analysis on salt, found that in a normotensive population, reducing salt dropped blood pressure by 2 millimeters of mercury only, compared with 5.5 to 6 millimeters in the hypertensive population. So salt may be important for the hypertensive population. Is it so important for the normotensive population? That's the sort of message that doesn't come through in the media. And I think that's where the media can play a big part, is in making sure the messages are honest. People can take them away and say, yes, this is now really true. Coffee is good for you, it's not good for you. I don't know which, but so I think these are the things that we can deal with in the media. And it's not really part of the Lancet's job. Our job really is to assess the scientific quality of research and put it forward for other people to look at. I'm not saying we're going to take one line and fit with that. We're going to take the research as it comes out. But the media's job in general, perhaps to make these messages clearer. And it's going to be very difficult, changing people's attitudes to the way they eat. What governments might be able to do, and health committees and bodies might be able to do, is actually to be a little more positive about some of the other things. Instead of stopping people doing things, maybe they should encourage people to do the right thing. Mm-hmm. Subsidies on fruit and vegetables may be a much more cost-effective way of introducing health benefits than trying to stop people smoking, drinking, well, not smoking, I think we can go along with that one, drinking, salt, fat, so on and so forth, and exercise. Give them the carrot, if you like, of much cheaper, highly subsidised fruit and vegetables. Probably does the job a lot better. I think it's contentious enough.
Okay, thank you very much. We will take some questions now, but I also want to quickly acknowledge and invite you to also direct questions to Professor Majid Azadi, who is here in the second row and is the lead author of the Lancet paper. Which what is the magic number of lives of deaths averted? 7 million.
37 million. 37 million. 16 million of them premature.
So if you could just say in one sentence the key takeaway from the paper, which was published Saturday. Sorry.
I think that the key takeaway is that the risk factor targets get us really close to 25 by 25. And if you make tobacco 50%, it gets us extremely close, almost there. So I think we actually can do it by prevention plus the sort of the two treatment targets.
Yeah, okay, and World Heart Federation, again, is committed to the hypertension and tobacco in particular, but also to the treatment targets as critical to averting deaths.
Kindly printed 2-page summaries, which I'm just going to
Okay.
sort of do if people want to take them, because this
Great.
actually sort of tells the story.
Great,
in 2
thank you.
pages in pretty simple, yeah.
Much easier, isn't it?
Okay, so could I take some questions then? Are there any questions from the floor? I think we've heard a really wonderful sort of spectrum of how rich and complex this issue is. We've heard success stories from Australia, but also some of the challenges both within Australia and in the Pacific region, in the backyard here. We've heard in Brazil great progress when cardiologists wear red and go red for women and start to try to address that gap. We've heard here in Australia again some of the continued challenges. I think we heard about the importance of persistence in continuing to try to address the cardiovascular disease burden. And of course, we've heard from Douglas about how WHO is really taking enormous leadership in tackling this issue, and from Stuart, the role of the media, and particularly around food. What do we do? It's a tricky and complex issue. Yes, one question?
Just curious how the panelists regard the phrase lifestyle diseases, which is often used to describe these, how that has an impact on people's understanding of these conditions, how it might have an impact on policymakers' concern about the burden. How do you regard the phrase lifestyle diseases? Favorable, unfavorable, neutral?
Okay. Why not? Look, I think it cuts both ways on a term like that. There's a bit of a risk that you end up blaming people. It's your fault, and it's a lifestyle you have adopted. Now, we know for many people, if we take the contentious point about food, and particularly salt, for many people, the sources of food that they have access to, they don't actually have an ability to consciously choose what it is they can consume. There's a question of what they can afford, and also how much salt is contained in food, you don't know. So if you are a person with normal hypertension, normal blood pressure, it probably isn't an issue. But if you are someone with hypertension, particularly someone without access to medication, if the kind of food you have access to is brimming with salt, it is a major problem for you. The other side, however, of a term like lifestyle diseases is it actually gets people's attention. It gets policymakers' attention. It is something which does encapsulate what the things you might have to tackle are. So I think it has some advantages and also some disadvantages. And I do think one of our challenges is to mobilise, to get people's attention, to enable a dialogue about what needs to be done on those issues. So probably from my perspective, it's more plus than minus, but there is minus and you have to be conscious of that.
Also, we have to counteract the propaganda of the vested interests like the tobacco companies that have used lifestyles, etc., as a term to indicate that WHO, governments are becoming nannies and trying to dictate the lifestyles of individuals, which are an issue which are sovereign, that you have your own right to choose, etc., but of course not showing the flip side of the coin, because the tobacco industry in their particular realm have tried to completely control the agenda and normalize tobacco use. It should be an issue of trying to create empowering environments where people then can make the right choices, as Jane has described as well too. So if we try to flip it on its head, as Jane had indicated, and refer to lifestyle choices and trying to empower and create the right environments for people to make the right choices, and I think we can use those terms, but they have to be used with caveats and clear definitions, and they have to be used as well to counteract propaganda by egregious entities such as the tobacco industry.
Other questions? Okay, yep.
Thank you. My name is Henry. In Kenya, I come from Kenya, and when the Cabinet Secretary for Health began talking about NCDs and the need to bring it up the public limelight, there was also a repercussion from medical people, experts from the infectious disease divisions. And we saw kind of public sparring between the infectious division and the non-communicable diseases. I don't know how that's being reflected in Australia and how you have tackled that kind of thing. The infectious division feeling that they're being sidelined, yet we still have, as Marcia said, we still have a big and huge problem about those common ailments that are killing people in the developing countries, I think.
So if I may rephrase the question, it's around how do we address, acknowledge or try to refute the perceived competition between infectious and non-infectious diseases, and how do we actually address what's often called the dual burden? Many countries, we see that here in the Pacific Islands, are addressing both, populations are dealing both with communicable and non-communicable diseases. Did anyone want to try to address that question, Marcy?
I think this is a real big challenge. The one thing about cardiovascular disease, and as a matter of fact, I do like that expression, is that it puts it on the patient's hand. I mean, you give them the knowledge that they can do something about it. Okay, you can change your lifestyle, you can exercise, you don't need any money to do that. You can try to eat better, you can try not to be obese, and especially you can stop smoking. You know, you can show them that they can save money and they can use the money for other things if you just give them the numbers that they spent with smoking. So what I like about this, that's why I like this sentence. Now, with the so-called neglected disease, this is more complicated. In places where you still have infectious disease and rheumatic heart disease and Chagas and all this, this has to be something done by the government. I mean, if we don't create the infrastructure for good housing and a better quality of life and access to health facilities and all that, this is very difficult to change. That's why nowadays in Brazil it's a big problem, because we have all these Cuban doctors going to Brazil as a political action of the country, just because they said that we don't want to go to the Amazon to treat people there. What is the point of sending one doctor to the Amazon if you don't have anything there? People don't have any housing, you don't have medicines, you don't have hospitals. What can a doctor do? I mean, if you go to a public university, I think you should pay back the government. But it's not just the doctor going to the Amazon. I think we need the architect, we need the engineer, the sanitary engineer, and we need the dentist, and we need all this. So the challenge is going back to your question, the challenge is very big, but I think what we can do about the non-communicative disease is making people aware that they can change it. And maybe this is much easier to change than the infrastructure that has to change to eliminate other neglected, so-called neglected disease.
Okay, thank you. Douglas?
Yeah, and I think this dichotomy between communicable and non-communicable disease is a bit of a straw man. I think it's a bit of a false dichotomy. It's a notion that we should work in public health and development in silos, which we know that integrated approaches are much more effective. We know now that certain major infectious diseases like HIV/AIDS are now chronic diseases. In fact, we, under the new initiative in WHO and with our partners, have signed a memorandum of understanding with UNAIDS, because many HIV/AIDS patients, both in developed and developing countries, are now dying of heart disease, and you need to work in synergy to strengthen health systems to be able to address both sides of the equation. And we know as well too that there are the cross morbidities with tuberculosis, for example. The main determinants of tuberculosis, yes, HIV/AIDS and other environmental conditions, but diabetes, alcohol, tobacco, smoking, it's estimated is the cause of 21% of new cases of tuberculosis worldwide. It's little known, it's underknown. A study in India a few years ago showed that up to 40% of deaths from tuberculosis are due to smoking. So Integration, I think, is the watchword, and I see the world community maturing, I think, as we're moving towards the Sustainable Development Goals to be adopted by the world community next year in 2015. Yes, very important to continue the unfinished business of the MDGs, including communicable diseases, maternal child health conditions, but also in synergy and in a more integrated fashion to also address non-communicable diseases. So I think it ends up to be, as I say, a bit of a straw man argument, and it probably doesn't really benefit the development objectives that we have to parse them out into silos. So.
Okay, thank you. We're reaching the end of our time here. Any last thoughts or questions from the audience? Okay, any last statements from our panelists? Okay. Well, thank you very much. Please do watch this spot for the production of roadmaps, which we're creating around these priorities. And World Health Organization, thank you. Thank you to the Government of Australia for being such fantastic hosts, to the Government of Victoria also. Thanks to the Lancet for tremendous leadership in this area, really. And of course, thank you to the Heart Foundation of Australia for being a fantastic partner and co-host. And thank you to InterAmerican Society of Cardiology and to Dr. Barbosa. Thanks, everyone.